From Kane Hall on the Seattle campus of the University of Washington, welcome to the inaugural Jill Bennett Endowed Lecture in Breast Cancer. Tonight, Closing the Cancer Divide, the Global Challenge. Now, please welcome the Dean of the University of Washington School of Public Health, Dr. Howard Frumkin.
Good evening. I'm Howard Frumkin, Dean of the School of Public Health at the University of Washington, as you just heard from that disembodied voice. On behalf of Paul Ramsey, Dean of the School of Medicine, myself, and all of us at UW, it is my pleasure to welcome you this evening to the inaugural Jill Bennett Endowed Lectureship in Breast Cancer, as we initiate a tradition of continuing Jill Bennett's legacy as an inspiring advocate for breast cancer care and research. Jill Bennett was a catalyst for collaboration, and she galvanized breast cancer researchers, physicians, and cancer survivors to work together to propel advances in patient care and treatment for this devastating disease. After Jill's passing in 2004, the Bennett family wanted to create a legacy for long-term impact. The Bennetts designated two areas of focus. The first was to support breast cancer research by establishing the Jill Bennett Endowed Professorship in Breast Cancer, which is held currently by Dr. Julie Graylow. The second was the creation of the Jill Bennett Endowed Lectureship in Breast Cancer, for which we gather this evening. This continues the tradition of the Mary Gates Lecture Series, which Jill established in her lifetime. I'd like to thank and salute the Bennett family, the Bill and Melinda Gates Foundation, and generous donors to these endowments. This is the right time and the right place for this evening's lecture for at least three reasons, each captured by a question. First, how do we set our priorities? Coincidentally, this week marks the annual Global Health Metrics and Evaluation Conference here in Seattle, a landmark event that reminds us that when data speak, we need to listen. In this case, the data tell a clear story. Breast cancer represents an enormous health burden. Fighting this disease must be a priority. Second, should we focus close to home or should we focus globally? The clear answer is yes. Breast cancer, like so many non-communicable diseases, is a health challenge not only in our backyard, not only in wealthy nations, but globally. As a global center of global health, Seattle is a fitting venue for tonight's lecture. Third, what tools do we need to use? Again, the answer is yes. Cancer requires the full spectrum, from laboratory science to epidemiology, from prevention to diagnosis to treatment to palliative care, from rigorous science to gentle, steady love. Here in Seattle, home to the Hutch, Seattle Cancer Care Alliance, UW's 6 health science schools spanning all the health professions, the Bill and Melinda Gates Foundation, and such jewels as PATH, the Infectious Disease Research Institute, and Seattle Biomed, to name just a few, we have the broad array of tools needed to address the cancer challenge. It is now my honor to introduce Mr. William Gates, Sr. Bill Sr., the co-chair of the Bill and Melinda Gates Foundation, is a bachelor's and law school graduate of UW. A founding partner at Preston, Gates & Ellis, he has served as president of both the Seattle-King County Bar Association and the Washington State Bar Association. Having served as a member of the UW Board of Regents from 1997 to 2012, Bill Sr. is the only person in our university's history to bear the honorary title of UW Regent Emeritus. He recently received the highest honor the university can bestow upon any graduate, the Alumnus Summa Laude Dignitas. A legendary champion of health, innovation, fair play, education, and opportunity, Bill Sr. has served as a trustee, officer, and volunteer for more than 24 Northwest organizations, including the Greater Seattle Chamber of Commerce and King County United Way. In 1995, he founded the Technology Alliance, a cooperative regional effort to expand technology-based employment in Washington. He's standing there wishing that I would hurry up and finish this introduction. So without further delay, please join me in welcoming Bill Gates, Sr.
You know, I didn't understand that Latin until very recently, and now I understand that the summa lauda dignatus, what that says is, Bill, you don't really have to wear a tie. That was a very nice reward. Well, thank you very much, Dr. Frumkin, for the good kickoff for this lovely and very important event. This is something of a bittersweet occasion for me, as I'm sure it is for a good many of you. Jill Bennett was a wonderful woman, a close friend of our family, and I still miss Jill very, very much. But when I recall all the things Jill was able to accomplish in her life, that's the sweet part. When my late wife Mary was sick with breast cancer, Jill, who had already been diagnosed, was by her side. When Mary passed away, Jill created a lectureship in her honor. Jill was energetic, fiercely loyal. That combination of attributes led her to commit amazing acts of devotion for the people she loved. That is why I think the Jill Bennett Endowed Lectureship in breast cancer is such a fitting tribute, and why the Bennett family and the Gates Foundation were so pleased to help endow it. Through the lectureship, Jill's brave fight against cancer continues her dream that a cure lives on. Jill is my heroine, and I have vivid memories of her laughing and striving and making us all better and happier people. It's nice to be able to say you really knew your heroine, and it's a great honor to be here this evening to pay tribute to her the only way she'd want, by pushing ever harder for an end to breast cancer. It's my pleasure to introduce the first holder of the Jill Bennett Endowed Professorship in Breast Cancer. Dr. Julie Graylow is University of Washington Professor of Medicine in the Division of Medical Oncology. She is Adjunct Professor in the Department of Global Health. Dr. Graylow is also the Director of the Breast Medical Oncology Department at Seattle Cancer Care Alliance and an associate member of the Clinical Research Division at the Fred Hutchinson Cancer Research Center. Without further ado, please welcome Dr. Julie Graylow.
Good evening. I'm thrilled to see all of you here, many of you who knew Jill, and others who are just learning about Jill. I thought a lot about Jill over the last couple of weeks leading up to this. What would she want from this? What would Jill do was kind of a constant refrain in my mind. She would want this to be big and splashy, and we achieved that. She would want this to be broadcast around the world, and we are live streaming right now. Who knows how many countries are watching this right now? So I looked through my slides and found a couple of slides of Jill's from the 2004 Mary Gates Lectureship. This was one that she used. It said, hosted by Northwest Cancer Partners, a group that Jill had formed in order to accelerate science to find the cure. And this slide with synchronized rowers says, synchronizing efforts for maximum power, leverage, and speed. That's what Jill was all about. She's like, hurry up, quick, I'm dying here. She said to me many times. And she wanted to get us all together to be talking about the problem and finding the cure. This is also from that 2004 Mary Gates lecture. And Jill was attempting in this slide to show the different pathways from getting an idea and working on it in the lab and then translating it into the clinic and getting it out available to patients. And she circled in this slide that Northwest Cancer Partners is here at the translation step. Jill was ahead of her time in being a translational researcher and trying to accelerate at that point. I think Jill would have been very frustrated to know that many therapies, many preventions, many devices that make it all the way to the clinic in the United States don't even have a chance of impacting most people in the world. And so I think she would be thrilled to have the topic of the first Jill Bennett Endowed Lectureship be on global health and cancer. So just to kick things off in the global health and cancer arena, myth. Cancer is a disease of developed countries. Fact. Low and middle income countries now bear a majority share of the burden of cancer. This is data from GloboCan 2008, the most up-to-date data, unless we saw some more recent data at the IHME meetings this week at the Westin. This shows cancer incidence and deaths as broken down in green by less developed countries and in red by more developed countries. With incidence on the left, you can see that more cancers are diagnosed in less developed countries. 56% of cancers in the world are diagnosed in less developed countries. And cancer deaths, there's even bigger gap, a bigger range. Less developed countries, a full 2/3 of cancer deaths are occurring in less developed countries, with only about 1/3 occurring in the developed parts of the world. In 1970, only 15% of all cancers diagnosed in the world were diagnosed in developing countries. In 2008, at the time of the most recent GloboCan data, it was about 56%, and we're projecting that by 2030, it will be 70% of the cancers diagnosed in the world will be diagnosed in developing countries. Myth. It's too expensive, and there are too many obstacles to prevent or treat cancer in developing countries. Fact. Much can be done to prevent, treat, and palliate cancer even in resource-constrained settings. We had a UN high-level meeting on the prevention and control of non-communicable diseases in September of 2011. This really jump-started the international world thinking about cancer and heart disease and pulmonary disease and diabetes in an equal way, hopefully growing sometime equally soon, to infectious disease and maternal child mortality. So the time has come to challenge and disprove the assumption that cancer cannot be prevented, treated, or palliated in developing countries. And that's the topic of tonight's Jill Bennett Inaugural Endowed Lectureship in Breast Cancer. With that, I'm pleased to introduce our first speaker of the evening. Her Royal Highness, Princess Dina Mired, is the Director General of the King Hussein Cancer Foundation in Jordan. She's the honorary president of the Global Task Force on Expanded Access to Cancer Care and Control in Developing Countries. As one of the leading figures for advocating early detection and screening of breast cancer for women in Jordan, Princess Dina is the honorary chairperson of the Jordan Breast Cancer Program. And as a mother of a cancer survivor, she knows firsthand the challenges cancer brings to patients and their families. I'm thrilled to introduce to you and to bring up on the stage Princess Dina. Thank you for joining us.
Good evening, everyone. I would like to begin by thanking first Dr. Julie Graylow, the Jill Bennett Endowed Professor of Breast Cancer, for inviting me to Seattle and giving me the platform to be here with you. And I feel especially honored to be part of the first lecture series in the name of someone who not only fought her cancer so bravely, but was a staunch advocate for finding a cure for cancer for others. I am certain that had Jill, the late Jill, been here with us today, she would have been a fierce advocate for global health as well. I would also like to thank the University of Washington, the Fred Hutchinson Cancer Research Center, the Seattle Cancer Care Alliance, and Dr. Julio Frank, Dr. Felicia Knoll, Dr. Howard Frumkin, Dr. Paul Ramsey, and Mr. Bill Gates Sr. Thank you for being here with us today, and everyone who came to this lecture. Divide and rule. This is what cancer is exceptional at. The cells divide uncontrollably, and left to its devices, cancer goes on to rule, causing great damage on its journey. Not only does it rupture health and inflict great pain, it rules every aspect of the patient's life and goes so far as to tear families apart. However, with the advent of technology and new discoveries, a cancer cell in the developed world, yes, will divide uncontrollably and will cause great damage, but thanks to the accessibility of state-of-the-art treatment, the cancer cell has a much harder time doing its job. It will be bombarded with expert surgery, the latest chemotherapy, precise radiotherapy, hormone therapy, targeted therapy by high-tech equipment, expert radiologists, and the like. And now, with the new frontier of personalized medicine, those cancer cells will now experience customized and targeted attacks. The narrative of a cancer cell in the developing world is very different. The battlefield is not equal. The cancer cell is the victorious enemy with literally no opponent. The battleground is depleted from basic chemotherapy medicines, sufficient oncologists, radiologists, and state-of-the-art equipment. A cancer cell in the developing world is not only left unchallenged, it is actually left to flourish. As a result, this year alone, 5 million people in developing countries will die as a result of cancer. 5 million lives lost, people with hopes and fears and dreams just like you and me. How many will die also in pain and suffering? Incredibly, this number is expected to double by 2020. This harsh disparity between the developed and the developing world with regards to cancer treatment and control was made painfully clear to me in a very personal way 12 years ago. Just 2 days shy of our son Rakan's 2nd birthday, my husband and I were told that he had leukemia. Rather than the joy of watching our toddler blow out his birthday candles, we found ourselves facing the multitude of emotions that a cancer diagnosis brings. Shock, sorrow, hope, and stronger than all of the other emotions, the paralyzing fear that we could lose what is most precious. Thankfully, I was able to travel thousands of miles necessary to ensure that our son received the best possible treatment and the best chance for a cure. And as Rakan received his life-saving treatment at the Dana-Farber Cancer Institute, I was able to watch our sliver of hope blossom and grow. By the grace of God, I am here today, able to say I am the mother of a cancer survivor. I am extremely cognizant of the fact that others did not have the same chance. As we speak today, global health vis-à-vis cancer is still an elusive and intangible concept. Interest in global health historically was spurred by the invasion of communicable diseases across borders. It became very clear that communicable diseases spread very fast and actually needed no background checks and no visas. One disease a continent away was able to knock on the doors of another in a matter of months if not checked. As a result, we saw great and necessary action taken on with regards to communicable diseases. The fight against them achieved major strides, both at the source and around the world. The work of the Gates Foundation on malaria and other diseases is a testament to that, and an example of what swift, global, united efforts to combat communicable diseases can achieve. Unfortunately, for the slow and painful killers of diseases such as cancer, heart disease, diabetes, and respiratory illnesses, the response was slow. These diseases were given the unfortunate label of non-communicable diseases, as if to say, don't worry, these diseases are not contagious, you can't catch them, we will deal with them later. They were not seen as urgent. That is why global health action in these diseases stalled. To further add insult to injury, these diseases, especially cancer, needed highly complex and specialized infrastructure, both in human and capital resources. Many countries in the developing world were unprepared to deal with such complex diseases, expounded by the fact that they had the double burden of also having to deal with communicable diseases. So a huge divide developed. And as we speak today, despite all the knowledge that we have and all the technology, a child in Africa with a highly curable disease such as ALL leukemia with a 90% cure rate probably will have at best 10% chance of survival. This deadly statistical standard deviation is unacceptable, unethical, and tragic. I often hear the word access to treatment mentioned here and there in speeches and conferences, as if it were only a matter of entering the door of some oncology facility. The term access to treatment is somewhat simplistic. For patients to truly have access to care, they must be able to physically reach the center or hospital offering the care, they must be able to verify the quality of care, and they must have access to the specific care needed for their particular type of cancer. More importantly, they must be able to afford the treatment. Access to treatment in the developing world is brought home to me every time an underprivileged patient comes knocking at the door of the King Hussein Cancer Center emergency room from a neighboring country that has no cancer care, with pleading eyes asking the simple question of, will you treat me? Access to care simply becomes access to life itself. Fortunately, we are here to talk about access to life for all, regardless of geography. We are here to talk about global health. But what does it mean in reality? For health to go global, the key word here is to go. Key elements of healthcare have to be mobile. They have to go global. One great achievement that will move the wheels of change is the new mindset with regards to non-communicable diseases. After the breakthrough September 2011 UN meeting on non-communicable diseases, the first and most important barrier to entry in the corridors of global health was removed. At the meeting, 36 million patients suffering from non-communicable diseases a year were finally acknowledged. As we speak today, great work is being done, article by article, working with countries to fine-tune targets and KPIs in order to reduce mortality from NCDs by 25% by the year 2025. This is an achievement in itself, especially after many years of denial that non-communicable diseases were problems only of the developed world. However, there are still many checkpoints and barriers to conquer. One important one is the fact that funds have not gone global. The war chest needed to fight non-communicable diseases is still non-existent. Developing countries can work on achieving targets on preventative strategies. But what about treatment? What about the millions of people who need treatment now? The world of cancer has many zeros to the right of any number. It is prohibitively expensive. Developing countries simply cannot have the resources to fight it alone. We need a war chest similar to that afforded to AIDS so that we can have the right punch in this fight. Another barrier for health to go global is the lack of healthcare professionals in developing countries, especially in the oncology sphere. Every conference I go to talks about the severe deficit of healthcare professionals. This is a serious roadblock to any efforts in promoting global health. Till today, doctors from developing worlds struggle to find placements for training in reputable institutions abroad. Sending fellows also abroad is very expensive and beyond the reach of many countries. However, there are solutions to jumpstart the process. We at the King Hussein Cancer Center saw firsthand what can be achieved when one forges real and practical partnerships between medical institutions. At the start of our journey, we benefited from two great partnerships, one with the National Cancer Institute and one with St. Jude's Children's Research Hospital in Memphis. The partnerships translated into sharing of treatment protocols, medical staff, and knowledge. St. Jude's Hospital even allocated a grant annually to help send some of our fellows abroad for training. Weekly and monthly consults and second opinions were done regularly through our telesynergy program, and still to this day, we share information and second opinions. These partnerships meant a great deal to our development and had a major part in our journey to becoming the only accredited comprehensive cancer center in the developing world that has disease-specific accreditation. We need more and more of these real partnerships such as these. We need to develop institutional medical CSR around the world. We need to develop regional training centers whereby doctors, as part of their training, have to spend a year abroad to teach and help develop capacity in the developing world. Alliances, task forces, working groups such as the Global Task Force for Cancer Care and Control in the Developing World, Partners in Health, and the work of the Fred Hutch in Uganda, and many others are examples of great efforts in spreading cancer equity across the globe. We need to stop talking about the shortages. We need to start talking about the opportunities for actions. Flow of medical information is another opportunity for the wheels of global health, to oil the wheels of the global health. In a world where we can get info at the press of a button, surprisingly complex medical information is not as accessible as you might think. Why? Because you need to buy it. Many countries simply do not have the budgets to do so. The King Hussein Cancer Center was able to log into the NIH Medical Library and have access to all the video conferences and medical journals online at no cost. This meant our doctors can now attend all conferences on any medical issue without having to leave their desk at home. This small but real example of health literally going global saved us hundreds of thousands of dollars that can now be spent on other urgent priorities. Global health cannot remain as a fancy term in textbooks. Global health has to become real and palpable at the shores of the developing world. And this involves all of us, even here in this room, to make it happen. Global health is not just the responsibility of the medical and health community. It is both the responsibility and privilege of all of us, advocates, donors, survivors, and governments, who adamantly believe that health simply cannot just be the privilege of the rich. As in the words of Jill Bennett, who fought her cancer with great courage and dignity whilst working hard to find a cure for breast cancer for others, even at her most vulnerable, I am told, she would say, "Why me?" But then she'd quickly shake her head and say, "Because I'm going to do something about it." So here we are today to do something about it. Together, we are going to work hard to become a powerful force of good in the fight for global health for all. Thank you very much. I would now like to invite to the stage another fierce advocate for global health on cancer. Dr. Felicia Knoll has become a great friend of mine and a great fighter in the fight for global health on cancer. Dr. Felicia Knoll is the director of the Harvard Global Task Force for Cancer Care and Control in the Developing World. Felicia, she had breast cancer in 2007, but like the person she is, she fought very hard to make sure that others have the same chance of treatment that she had herself in the Fred Hutch and also in Mexico. Seeing the disparities firsthand, she became an amazing advocate for all cancer patients around the world. Please welcome Dr. Felicia Knoll.
It is a tremendous responsibility to be here sharing this podium with others, and in honor of a woman that I was never able to meet in person, but feel that I have met perhaps through my friends and through her family who are here and through our physician, Dr. Julie Graylow. It's a tremendous responsibility because I share that feeling of outrage, of injustice, of a certain sense of sickness in my soul when I see a woman who doesn't have the access to treatment that I had and that I still have, and particularly when I see that woman in the country I call my home, Mexico, or in other developing countries around the world. It is a tremendous honor, but also a wonderful opportunity to be able to share this stage, but also to be able to make use of this platform, as Princess Dina said, as a way to change that reality for so many women, children, men, human beings around the world. I'll be sharing with you what started with my own story, diagnosed in a small clinic in Cuernavaca, Morelos, Mexico, in my first baseline mammogram at age 41 with no history of breast cancer in my family. I was primarily treated in that country that I call my home in Mexico, but the orchestra of the physicians and many professionals and friends who managed my treatment was led by my friend and my physician and my colleague, the Co-Secretariat of the Global Task Force on Expanded Access to Cancer Care and Control, Julie Graylow. I shared this journey with our other speaker this evening, with my husband, Dr. Julio Frank. As you'll hear in a minute, he at that point had just completed 6 years in the Ministry of Health as the Minister of Health, the Secretary of Health of Mexico, and started a truly wonderful program, the Seguro Popular, and one of, I think, the world's most elegant and important health reforms. But here, as you see in this photo, he was sitting in a hospital bed with me, as he did so many times, because he shared this journey with me. We learned about health systems together, and we learned a lesson about what he will probably call the true cancer, the cancer of stigma and discrimination that prevents so many women from coming forward earlier when they think and sometimes know that they have breast cancer. He was the one who said to me, who said to our 2 daughters, Mariana and Hannah, and has said to every woman and man in Mexico who will listen, that a woman is more than her breasts, that you do not abandon a woman who loses her breasts, and that we have to truly fight against the stigma of discrimination that's associated so often with cancer and so often with the situation of women. Now, we are trained, in my case perhaps mistrained as an economist, and so what we did was to turn that personal testimony that's written in a book available in English and in Spanish, Tómatelo a Pecho and Beauty Without the Breast, to turn to the evidence to try to look for solutions to this situation. We quickly realized that it wasn't enough to advocate on behalf of one's own disease only, and that one had to see the many diseases that individuals face. And that's why we took up the cause of cancer, all cancers in developing countries. And what I'll share with you is what we have produced in a book called Closing the Cancer Divide that is co-edited myself, Julie Graylow, Afsan Badalia, who's here with us today, and our colleague Rifat Atun. That book is the work of this global task force. This task force that includes 32 leaders in global health and cancer, co-chaired by Dr. Julio Frank and Dr. Larry Corey here from the Fred Hutch, and with our honorary president, Princess Dina Mired, who's led this charge throughout. What's unusual about this global task force is it's a summation of leaders in global health and leaders in cancer. It epitomizes what I'll share with you, this idea of a diagonal approach, because it tries to ask the questions of how we can at the same time strengthen health systems while responding to a specific disease and its needs and requirements of these patients, the so-called vertical, which is cancer care. The book itself applies a diagonal approach as a way of breaking down what's been one of the greatest barriers that has plagued global health throughout the last decades, which is epitomized in this fictitious battle between communicable and so-called non-communicable diseases, rather than thinking about the true needs of patients across the life cycle and the life cycle of their diseases, and how we can all work together so we're not helping those cells to divide, as Princess Dina said, but rather working together to make sure that we are preventing them from going in directions they shouldn't go. The framework for this report focuses on 4 myths about cancer. One, that it's unnecessary to do anything about this disease in developing countries because it's supposedly not a major health problem for the poor. Second, that even if it's necessary, it's unaffordable, it's too expensive. Third, that even if you had the money and you accepted that it was necessary, it's just impossible. And finally, there's this rather heinous idea among many that even if you could, it would be inappropriate to do something about cancer in developing countries because we would somehow be taking resources away from the supposed diseases of the poor. We break down those 4 myths, and we attest to the idea that doing something about cancer and expanding access to care and control in developing countries is something that should, could, and can be done. In 5 chapters of that book, we talk about different ways that this can be done, all the way from delivery through to stewardship, and I'll share a little bit of that with you in the rest of these slides. We developed the idea of a cancer divide in this volume, and the idea of the cancer divide is that cancer is indeed today a disease of both rich and poor. But, and especially if we do nothing about it, it will be increasingly the poor who suffer exposure to risk factors like tobacco, deaths from preventable cancers associated with infection, death and disability from treatable cancers, stigma and discrimination, and the pain and suffering that goes along with avoidable cancers. I'll go through only the last 3 of those aspects of the divide. The first, the opportunity to survive should not be defined by income or geography. This was a line, a sentence, a phrase that was shared with us in one of our first conferences on breast cancer in Harvard in 2009 by Princess Dina. And we tried to graph it as we've done here. On the y-axis is the ratio of mortality to incidence. You can think about that as lethality, the probability of dying from cancer. And on the x-axis, countries are lined up from poor, low income, to rich. We could argue for a long time about the slope of those lines, but what no one can argue is that they are all downward sloping. What we've graphed here for you are cancers that can be treated. We know there are some that really cannot, and those would be a flat line. But these cancers can, and there are many of them, epitomized by the situation of children that you see on your left. In Canada, almost 90% of children with leukemia can hope for survival, whereas in the 25 poorest countries of the world, only 10% can dream of surviving the disease if they're diagnosed with leukemia. That fourth facet of the divide is stigma and discrimination. We know that in developing countries that typically lack the kind of laws and institutions that can offer the protection that we patients need, the stigma and discrimination that are associated with cancer layer themselves on to existing discrimination around gender, around ethnicity, around poverty, and often around age. And that fifth part of the cancer divide, what we've called one of the most insidious of injustices, the lack of access to pain control. These maps blow up the world in ways that talk about access rather than geography. You see North America, basically Canada and the United States, blow up like an enormous balloon, and the rest of the world basically fade away. And that is because of the enormous inequities in access to pain control around the world. We know that for the poorest 10% of the world's population, consumption of opioids for people with HIV or cancer dying in pain is only 56 milligrams per capita. In the 10% richest, it is almost 100,000. And in Canada and the United States, it's close to 200,000 milligrams per capita. These medications, a sign basically of justice and a human right, are not only required for cancer patients, they're required for all patients. Yet we see the injustice of the cancer divide flowing clearly through this kind of a map. Up till now, we've talked really about equity issues, and I framed the reason why we believe that cancer is an equity imperative. But if you look at the changing reality, simply the health burden of this disease, you also see the reasons for action. These are data from the Institute for Health Metrics and Evaluation that, in effect, just had its conference ended today in Seattle at the Westin. These are data that were just published in The Lancet very recently, and we've brought them together to look at the cancer burden. What I found incredibly important to see here is how disability-adjusted life years, which combine death and disability from cancer, have in fact gone down a little bit for high-income countries over time between 1990 and 2010. Yet, in the low and middle-income countries of the world, these have increased substantially. The same is true of deaths. But what you're seeing in these numbers, the most recent for 2010, is precisely improvements in the probability of surviving the disease and the number of years you survive with the disease because of what institutions like the Fred Hutch and the Seattle Cancer Care Alliance are doing for patients like myself. Yet, we're at the same time seeing what happens when patients from around the world living in developing countries don't have that same access to those technologies that will continue to change the reality of cancer for those who have access because they have funds. One of the most surprising figures we find about cancer is when we share the situation of children. We normally think about children in developing countries as dying from other sorts of diseases. Yet, as my husband would say, we're in some senses victims of our own success. As we've seen children surviving from many communicable diseases, thanks to the work of great institutions like the Gates Foundation, we see new challenges emerging for children. Not surprisingly, cancer is the #2 cause of death in wealthy countries for 5 to 14-year-olds. But it is the #3 or #4 cause in middle-income countries, and even in the poorest countries in the world, it figures among the top 10 causes of death. So you see 85% of cases, yet 95% of deaths from childhood cancer happening in developing countries. Health systems are faced with a double burden. The cancer transition is an epitome of the epidemiologic transition. Low and middle income countries increasingly face both infection-associated cancers, but also all other cancers that aren't associated with infection. This means that cancers increasingly of the poor, only of the poor, are not the only cancers affecting or faced by the poor. The most obvious set of statistics that help to understand this is the comparison between cervical cancer, an infection-associated cancer, and breast, a non-communicable disease. Low and middle-income countries today account for more than 95% of cervical cancer deaths. This is becoming a disease from which only poor women die. Yet at the same time, 60% of breast cancer deaths. And both are leading killers, especially of young women. If you look at the data from, again, my home country, Mexico, I think you see this very clearly. We have 50 years of mortality data graphed in the top, running from 1955 to 2010. The blue line is cervical, and the pink line is breast cancer. A tremendous improvement in mortality rates, down from about 16 per 100,000 to below 8 in cervical cancer. And as of 2006, breast cancer is the #1 malignant tumor killing women in Mexico. Yet if you look at two states, a rich state, Nuevo León, and a poor state, Oaxaca, you see this double burden. In a state like Nuevo León, breast cancer overtook cervical cancer deaths by the late 1980s. In a state like Oaxaca, women are still dying in larger numbers of cervical than of breast cancer, yet that gap is closing. This is a country that has to face both kinds of challenges. When you look across the world at why young women die, you see a changing picture. We have some tremendously good news about mortality in childbirth, a decrease of approximately 35% in 30 years, so that today about 343,000 women only are losing their lives in childbirth. If you compare that to breast, cervical, and diabetes, about 100,000 more women die per year in developing countries from those diseases. What is the message that we should take from these numbers? The message is absolutely not to stop doing something about mortality in childbirth. No woman should die the day that she's giving birth to a child. But at the same time, it makes no sense, and it's a terrible injustice, to allow a woman to die from a preventable cancer or from a disease that could be treated and cured only a few years after having given birth to that child or adopted that child. It's a travesty and a waste of a tremendous investment that's given us a tremendous degree of hope. So we have a much more complex set of challenges that go alongside in dealing with this host of challenges facing women. And how do we do that? That is the so-called diagonal approach that's becoming more and more a claim of how we can move forward in health system strengthening in developing countries. Rather than focusing on either disease-specific vertical or horizontal systemic programs, you harness the synergies that provide opportunities to tackle disease-specific priorities while addressing systemic gaps and thus optimizing resources. As you'll see through the rest of the presentation, it doesn't come as a surprise that these came from two individuals in Mexico. This idea was Julio Frank and a dear friend, Jaime Sepulveda. Diagonalizing cancer care in financing and delivery can be done. You integrate cancer care and control into national insurance and social security programs, typically beginning with cancers of women and cancers of children. You can harness platforms by integrating breast and cervical cancer, prevention, screening, and even survivorship care into maternal and child health, sexual and reproductive health, HIV/AIDS, and even into social welfare and anti-poverty programs, thus harnessing much larger opportunities to be able to truly scale up these interventions. There are positive externalities when we identify and implement diagonal approaches. Promoting prevention and healthy lifestyles is prevention of risk for cancer, but also for many other diseases. Reducing the stigma around women's cancers, and I find this a tremendously comforting idea, reduces gender discrimination overall. It's not just about breast cancer. It's about the messages that breast cancer can give to strengthen the voice of women in many different areas. Pain control and palliation, we know that reducing barriers to access, essential for cancer, but also for so many other diseases, and even for strengthening platforms as broad as surgery. Using a diagonal approach, We know that investing in cancer care and control is not too expensive. Quite the opposite. It's something that we cannot afford not to do. We are losing money globally by not doing more on prevention and the most basics of treatments around the world. Tobacco costs the world 3.6% of GDP annually. Cancer, our estimates, in 2010, between 2 and 4% of global GDP. A third to a half of cancer deaths are considered avoidable. That's between 2.4 and 3.7 million lost lives, 80% of which are in developing countries. But furthermore, our calculations suggest that investing in prevention and simple aspects of treatment could literally save the world annually between 130 and 940 billion dollars. So we've broken down 3 of these myths: that it's necessary, it's affordable, and it's appropriate to do something about cancer in developing countries. The question now is it possible? And this is where we turn to the example of Mexico. I will share with you only the human face and a little bit of what a small NGO can do. The human face of financial protection for cancer is epitomized here by a dear friend, Abish Romeo, now 25 years of age. She self-diagnosed with breast cancer while legally resident and working as an au pair in Boston. Unfortunately, she was convinced that she had to leave her job because she had cancer. Therefore, she lost her work permit, and therefore she lost her visa, and was faced with no other choice than to go back to Mexico. And when we spoke on the phone, finally reached out to her, she said to me that her greatest fear was that she would impoverish her father. Her mother had died 2 years earlier of breast cancer in Mexico. She would impoverish her father by needing treatment for her breast cancer. And I was able to tell her that the minute she stepped foot in Mexico, she would be covered by the Seguro Popular. In the case of Guillermina, I met her in a chemotherapy unit in Jalisco, in Guadalajara, Jalisco. And to my great surprise, she had this lovely smile on her face, despite the fact that her breast cancer had just recurred. And the reason she smiled at me was because she said that the first time around, her children had been impoverished by paying for her care. This was before the Seguro Popular, the reform that brought it into place. But this second time around, she said, she was very tranquil because she knew that she would not be a burden to her family. We face challenges even with that kind of financial protection that offers a full range of treatment to women with breast cancer. The challenges of providing palliative care. We face tremendous challenges in achieving early detection. As we learned when we met Juanita, who was diagnosed very late in her disease. She came forward when she could no longer move her arm because of the size of her tumor. We asked ourselves why that had happened, why we hadn't been able to do a better job of harnessing an incredible primary sector of care, and we came up with a couple of answers. We looked across this disease, this chronic disease, breast cancer, and we realized that to do the job of really meeting this challenge and helping women, one had to think about primary prevention, early diagnosis, early detection, treatment, survivorship, and palliation. We looked across the Mexican health system and said, well, we need a little bit more push on early detection, diagnosis, survivorship, and palliation. But we have a large exemplary investment in financial protection for cancer through the Seguro Popular, a low survival rate that we can change, and so a huge opportunity to be able to improve delivery. I most often work in a country where I have the luxury of saying, if I just find that woman early enough, I can get her treatment. In most other low and middle income countries around the world, we still have to face the reality that if you find that woman on time, you still have to find the funding to pay for the treatment, just as Princess Dina said. What we did on the primary prevention side was to try to harness the primary level of care working through our NGO Tómatelo a Pecho with the National Institute of Public Health of Mexico and with this incredible program, the Seguro Popular. We've trained thousands of promoters, nurses, and doctors to be able to do a better job of helping women like Juanita to get earlier access to the care, the treatment that's offered through this exemplary system. But none of this would have been possible if it were not for a health reform and for the Seguro Popular that took effect in 2004. And that gives me the opportunity to introduce and offer the stage to my husband, Dr. Julio Frank. And I can only tell you that this is considered one of the most important and elegant health reforms in the world. But more than that, it's a reform that's allowed me to say to women like Abish that they have the hope of accessing all the same treatment that I had. And that was the most tremendous of gifts that he ever could have given to someone who got breast cancer. Thank you.
Good evening. It's really a great honor for me to deliver, alongside with my wife, the inaugural Jill Bennett Lectureship. Like Felicia, I didn't have the great privilege of meeting Jill, but I think mostly through talking a lot with her family and mostly through everything that Julie has told us, we can realize what a great woman she was and what a great legacy she has left. I'd like to thank Julie Graylow for the invitation and also congratulate her on holding the first person to hold the Jill Bennett Endowed Professorship in breast cancer. I have an enormous debt of gratitude to Julie. Seattle became almost a second home at that point when Felicia was diagnosed with her breast cancer. I was then working at the Bill and Melinda Gates Foundation, having finished 6 years as Minister of Health in Mexico. I came here as I was second senior fellow at the foundation, following on the footsteps of Bill Foege, a great giant, a hero of global health. And as I was working here, this was the place where we thought we would try to seek a complementary care for Felicia. And that's how we were immediately referred to what was described to me as the best physician to deal with breast cancer, Julie Graylow. And through that, well, we just saw the results. Felicia is here. She's doing a great job, and I'm eternally grateful to her for all of that, and of course for inviting me to be with all of you today. And it's of course a great privilege to share the podium with Princess Dina Miret, who's also an admirable woman, with Bill Gates Sr., whom I also learned to admire during my years at the Gates Foundation, and subsequently with my colleague and friend Howard Fromking, and with Felicia. But I'm not going to tell you so much about our personal history, except to say that having spent all those years leading a health system, I went from leading to living a health system, to being the companion to a patient, and I learned much more about the workings of the health system through that personal experience of trying to be a worthy companion of a patient. But that experience came on the heels of what was a major reform, and what I would like very briefly to tell you about, because I realize it's late, so just very briefly to tell you about that experience in Mexico for one simple reason, because it underscores the notion that this is actually possible, that Mexico, although it's a middle-income country, it's not the poorest country in the world, but it has a lot of very poor people. And if it can be done with some of the poorest people in Mexico, I think it can be done almost everywhere. This was a large-scale reform, but cancer played a central role because it helped to focus attention on achievable goals, and then that reform extended to benefit other diseases. This is what Felicia has called the diagonal approach. Let me just give you a little bit of context of why this reform became necessary. We have been going through the period of most intense change in health in human history. Just think about the fact that at the beginning of the 20th century, life expectancy at birth in the world, including the United States, was about 30 years. That's what any person born in 1900 could expect to live. By 1985, that had more than doubled to about 63 years, 64 years. So it means that in that short period of time, humankind experienced a larger gain in life expectancy than all its previously accumulated history. But the important thing was that that amazing increase, which accelerated after World War II, and which was driven by advances in knowledge that was then applied to vaccines, to better drugs, to diagnostic methods, but knowledge that was also internalized and empowered people to lead healthier lives. That health revolution of the 20th century completely changed the human experience of disease. Until the 20th century, what happened with disease was that it was mostly an acute episode. We got sick from something, and then we either died from that or recovered, only to go and get the next episode, which again, we either died from that or went on to acute. It was a succession of acute episodes. And through this health revolution, instead of being a succession of acute episodes, diseases became a chronic condition with which we spend substantial periods of our life. It became a condition of living, and it shapes even the way we talk about disease. People say, I am a person who lives with cancer. I live with cancer. I live with HIV/AIDS. People say, I am diabetic. It becomes part of your identity. Very often a stigmatized identity, an identity that's subject to discrimination. But that's been the fundamental shift in our experience of disease, and that is a recent phenomenon. And what that led to was a major transformation in the dominant causes of disease, disability, and death around the world. For most of human history, this succession of episodes was marked by external causes, typically a bug, a bacterium, or a virus that infected you and killed you, typically in early childhood. And now we live with complex diseases that are a product of environmental exposures, our genetic endowment, and our own behaviors. And although that progress has not been uniform around the world, and we still have a lot of places in the world that are still lagging on basic control of infectious disease and maternal mortality, by and large, we have seen this enormous shift. The world today is facing the double burden of disease. There's still a huge unfinished agenda of common infections, maternal mortality, undernutrition. But at the same time, without having solved that, most of the world now experiencing this growing burden of chronic diseases, the so-called non-communicable disease, of which cancer is the exemplary case. What happened with that, though, was also an economic change. We more or less have been able to deal and eliminate and control diseases that are relatively inexpensive to prevent and treat, that can be prevented and treated usually with very effective and inexpensive vaccines. We've eradicated smallpox. We're about to eradicate polio, thanks to a large extent to the leadership of Bill Gates and the Gates Foundation. Those are diseases that are fairly inexpensive, and they've been substituted by diseases that are much more costly to diagnose, prevent, and treat. And because most countries in the world, and not just poor countries, have not created the social instruments to deal with the economic consequences of ill health, what we see today is a huge amount of people, between 300 and 400 million people around the world, that every year become ruined because a member of a family experiences one of these diseases like cancer. Now that, in the case of Mexico, was the motivation for this reform. Because thanks to very careful analysis, actually done by Felicia herself and her team, because she revealed at the beginning that sin of hers of being an economist, they had actually estimated that so-called catastrophic health expenditures affected about 4 million people in Mexico. And no one had actually seen that reality. 4 million people who had to face this horrendous choice between either selling everything they owned and going into poverty or trying to save the life of a dear one. Now that choice was also faced in this country until the passage of the Affordable Care Act, and not just the passage, it still has to be implemented. But even in this country, paying for care is still the #1 cause of personal and firm bankruptcy. And there are also several million people in the US who become totally impoverished because a member of their family has to pay for care. And that leads to what I've called the unacceptable paradox. Today we know that improving the health of people is probably the most effective way we have to deal with poverty. Because when people are poor, the best thing you can do is provide education and better health. And that will allow them to lift themselves out of poverty. And the paradox comes because far from being a way of lifting people out of poverty, paying for care becomes itself a major cause of impoverishment. And that was what led to this reform. In the year 2000, when I was appointed Secretary of Health, I must declare that I am not a politician. I was working at the World Health Organization, but a new regime, the first fully democratically elected government in Mexico, wanted to recruit some of the members of the cabinet from so-called experts, and that's how I was brought back to Mexico to lead the ministry. And I had been spending many years of my life studying these problems. So we were able to rapidly diagnose the situation, and the situation was that year, in a country of 100 million people, half of the population, about 50 million people, were uninsured. And that half of the population were the poorest people in society and were the people who were experiencing these catastrophic expenditures. I'm not going to tell you everything about this reform because actually we wrote into the legislation the obligation of doing evaluation. So actually a lot has been written about this reform. It has led to many, many articles in the medical literature, and anyone who's interested, I can provide you with a long list of papers, so I'm not going to give you the details. Let me tell you that the basic element of this reform was something that's actually the same situation as in the United States. In many parts of the world, including the US, including Mexico, including China, the problem was that access to insurance became a benefit of employment. If you had a job, you had insurance. That was the situation in the US until now, the Affordable Care Act. And that was the case in Mexico. And half of the population had a job, and they worked for someone, and that provided them social insurance. But half of the population, the poorest people, were either self-employed or unemployed or altogether out of the labor market, like full-time homemakers or students. And that half, 50 million people, didn't have insurance and were the ones who were experiencing these catastrophic payments and these tragic choices between driving yourself into poverty or trying to save the life of a dear one. So in order to deal with that, we introduced a new insurance scheme, and that's what Felicia has been calling Seguro Popular, or popular health insurance. It was an insurance designed specifically to cover poor people. The important thing with that was that rather than going and asking for more money for health, what we did was start with the end in mind. We said, what is it that we need to achieve? What are the results and the deliverables that we're going to offer society? And we started with some goals, then translated that into the necessary services that would allow us to achieve those goals, calculated what would be the demand for those services once you remove the financial barrier by providing insurance, costed those services with a certain standard of quality, and that led us to conclude that the country was underfinanced by about 1 percentage point of GDP was missing. We were lacking that money to provide access to all of those services to achieve those targets in terms of health improvement. Now, for the non-economies, 1 percentage point might sound like very little money. It's actually a lot of money. Mexico is not a small country. It's not as large as the United States, but it's still the 13th economy in the world. So 1 full percentage point of GDP invested in health was a substantial amount of additional investment. But the key here was to say, yes, we need more money for health, but we will offer more health for the money. And the key in doing that was to be very explicit about what were the goals we would achieve. And we started with emblematic diseases that caused these tragic choices among families. And the first one was leukemia among children, because that was exactly the case. Before this reform, 30% of kids with leukemia, which, as you have heard, is not just a treatable, it's a curable disease today. 90% of children with leukemia in Canada will be cured. Well, 30% of children with leukemia in Mexico started their treatment and had to abandon the treatment because the family ran out of money. Those families had the worst of both worlds. They drove themselves totally into poverty, and the child still died because they ran out of money. That was not fair. And instead of telling them, these abstract financial and actuarial notions of health insurance, it was humanizing the problem by talking about kids with leukemia that actually gained an enormous amount of support for the reform, and it was passed with a lot of support, not exactly like in the US, from all parties, and everyone decided to support this and support this additional investment of 1 percentage point of GDP. Breast cancer and cervical cancer were others of those, and again, it was a way of putting a human face, like you just saw, into some of these abstract notions about health insurance. The results are dramatic. The law gave us 7 years to cover all of those people. The law came into effect on January 1st, 2004. So the deadline was December 31st of 2011. And I have to tell you, by then there was a new government. There was a change of government. But because this was built into the law, and because we did a lot of good evaluations that showed that the program was working, even with the new government embraced it and continued the program. And in March of 2012, only 3 months late, which frankly, for any government, is pretty good, we had in Mexico the visit, the Director General of the World Health Organization and some of the top leaders in health in the world certified that Mexico had achieved universal coverage. By then, 52 million people had joined this new insurance scheme, and Mexico had achieved universal coverage. And the numbers are dramatic. I told you that 30% of children with leukemia had to abandon the treatment. That percentage is now down to 3%. With breast cancer at the leading hospital in the country, it's even more dramatic. Also, about 35% of women with breast cancer, their families ran out of money, they abandoned treatment, they became ruined, and the woman still died. That is now down to 1%, 1% of women. And that's exactly what can happen. This is a worldwide movement. It's not just Mexico. It's also now the US. This is the year where a lot of this will be implemented here. It's China, which had exactly the same problem and is about to finalize the largest drive of expanding health insurance in the world with 1.2 billion people. I remember when the Minister of Health of China visited us because he wanted to see our program, and he said, we have exactly the same problem as you, exactly the same problem, insurance tied to employment. The only difference is you have 50 million uninsured, we have 600 million. So other than that small detail, it's practically the same. Well, the Chinese are now about to achieve something like that. That's the power of focusing on concrete deliverables and being able to tell people what they're going to get out of these additional investments. Let me finish by telling you that this was not just an insurance program. This was a comprehensive reform. It included, yes, the funds for the insurance, but it also included interventions and actually a separate fund for what are the upstream determinants. If you just insure people and remove the financial barrier and you do nothing to prevent people from getting sick in the first place, you're going to break the system. I mean, it's going to go broke. You can't afford it. So we created a separate fund called the Fund for Community Health Services for prevention. By the way, the Affordable Care Act has exactly the same provision. There's a fund to invest in public health so that you do the upstream savings. And those map very nicely into the different gaps that Felicia was talking about, the different elements of the cancer divide. For example, out of that fund, where Mexico is now providing full coverage for the human papilloma virus vaccine, which is the way to prevent cervical cancer. And about 1 million girls between 10 and 11 years now receive that vaccine. That's closing that first gap on prevention. Similarly, that fund has funded a very aggressive set of measures against tobacco, again, to deal with the upstream components. It has also dealt with all of those services in health where there's no spontaneous demand, like early detection, because you don't feel sick, you don't demand those services. And that has led to enormous increases in the coverage of early detection for diseases like breast cancer or cervical cancer. So that's the story. It shows that it can be done. It can be done in a fiscally responsible way, in a way that's been affordable. 1 percentage point of GDP over 7 years. Every country, even the poorest countries, can afford that. If they don't, it's because they don't have the political will, or they've decided that other things, other priorities are more important than saving the lives of children and women from cancer. And that's, a matter of political will. But let me finish by saying that all of this, however, is not enough. Because there's that other divide, the divide that leads to stigma and discrimination. And we also need a cultural change. By accompanying Felicia, I had the chance to talk to many, many women who would tell me, I'm not going to take a mammogram because if I am diagnosed with breast cancer, my husband will abandon me. And that led me to believe and verify that alongside breast cancer, you have a social cancer, the cancer of discrimination, the cancer of reducing women to a part of their bodies. And I think, and that's why I have embraced this cause along with my wife, because I think we men have a very important role to play in this fight. We can choose to be either a big part of the problem or choose to be a part of the solution if we learn to be good companions, and if we see the fight against cancer as a fight for the dignity of women, which in many parts of the world is really still very much needed. So let me close by saying that it's exactly the example of great women like Jill Bennett that I hope will guide us all to persevere in the fight against cancer, and through that fight to really look forward to a much better world. Thank you very much for your kind attention.
Thank you for 3 spectacular presentations. Could I invite Princess Dina, Professor Knoll, Dean Frank to have seats at the table here, and we'll have a few minutes for discussion and questions. If you have a question or a comment, there are microphones at each side of the auditorium. If you're stranded in the middle and can't get to a microphone, you can just raise your hand and I'll recognize you. Please identify yourself if you would. And if you're not at a microphone, I'll repeat your question so that UW-TV and the rest of the audience can hear what you have to say. Questions or comments? Sir.
Could you speak to the technologies and the types of therapies, research and development that would have the most effect on developing countries and get the best return on the investment?
The question was about the technologies that would give us the best return on investment in developing countries.
Well, the economist should.
Well, I could answer like an economist, but I think first I'll answer like someone who has breast cancer and say that although we have very little way of measuring it, doing something about stigma and discrimination will make an enormous difference. I know that probably wasn't the exact answer you were looking for, so I'll go through to more of the technology parts. We need to understand better how to do the implementation, and I think we require research that can really tell us how that sort of a diagonal approach can work. We need to be able to go from small programs to programs that we can effectively scale up in ways that are inexpensive. And when you layer those on to existing programs, they're very inexpensive. But what we don't have is the accumulated evidence about how to implement those, which will come from evaluation. So that's one answer. Now, the other is that we have a host of possible interventions, all of which seem to be very cost effective and that range from prevention on through to treatment, and of course also the palliation. One point on pain control and palliation is that we never measure the value of taking away pain. It's invaluable, but it doesn't extend your life and it doesn't make you any more productive. So none of our existing measures are any good. We needed new measure of that particular point because it is, in fact, invaluable. That said, in Closing the Cancer Divide and with a group of oncologists, including Julie, there are a series of interventions that were highlighted ranging from prevention, tobacco, obesity, the HPV vaccine, exactly, and on through to a series of interventions like several chemotherapeutic drugs. And in the end, what this group of oncologists told us was that only 3 of the 29 recommended chemotherapy agents for developing countries was on patent. All the rest are generics that are of low cost. So the book has a whole host of possible areas that we can, in fact, invest in. But I don't know, Julio, did you want to?
No.
Yes, sir.
My name is Kingsley Ndo. I'm a physician from Nigeria and a recent Master of Public Health graduate from the University of Washington. And my question goes to Her Royal Highness Princess Gina. I wanted to find out how you staffed the King Hussein Cancer Center with oncologists. How did they get trained, and where did they train? Because human resources is a very big challenge in Africa in terms of cancer care and prevention. And I just wanted to know how King Hussein Foundation overcome that challenge.
The King Hussein Cancer Center story is really nothing short of a miracle. That's how we look at it. Actually, one of the main reasons for our success to finally becoming a life-saving institution, offering the best chance for a cure for our patients, not only in Jordan and the region, was mainly, one of the main reasons was to reverse the brain drain. I am very sure that there are probably, hundreds of Nigerian doctors who came to study in the US and Europe and never went back. And I think this is what happened in Jordan. When the center first opened its doors, we only had 4 full-time oncologists, 2 for pediatrics and 2 for adults. Now, with the reverse of the brain drain, we now have over 200 oncologists and consultants. And how did we do that? Basically, we were very serious to making sure that we are laying the foundation for a proper system of comprehensive cancer care. And this is how we attracted our doctors. Doctors moved for lesser salaries, by the way. It's not just, doctors enter the field of medicine not just to make money, to help humanity. And so they moved from top salaries to okay salaries living in Jordan because they felt they could do a huge impact, save lives. But the main thing was that we offered a proper system of comprehensive cancer care. And I know in many developed countries, they make the mistake. They think all they need to do is just build the building, buy the machinery. That's the easiest part. The main part is to fill it up with the proper system so that healthcare professionals can see that they can further their careers and that it is very similar to top institutions in the world. And I think that's what the King Hussein Cancer Center achieved. And I'm sure you can achieve it in Nigeria. But you need to go back.
Yes, sir.
Hi, Dr. Landerholm from just up the road in Edmonds. I'm a surgeon. Faced and introduced to kind of a very complex puzzle and a daunting issue. Recently returned from a trip to Kenya, where we were approached by a religious leader there as well as a physician working in Nairobi. And they approached us on this very subject. How do we raise awareness? How do we bring in diagnostic capability? And how do we set up the infrastructure to actually take care of our people? So I didn't realize I was going to be part of that conversation, but we said we would investigate what the possibilities are. So my question to this very distinguished panel is, where do you start that process?
Most health systems in poor countries are part of a vicious cycle. They are underfunded, therefore the quality is poor. Poor people don't go there. So because no one uses the few hospitals or clinics, then no one feels that they need to invest in that. And you gotta break that vicious cycle. I think a good way to do it is, first of all, to have good evidence, to have good data that shows what's the magnitude of the problem. I learned that the most important attribute of a minister of health in a developing country is to learn how to talk to the minister of finance. And you know, if you think that you're going to get there with moral persuasion, it doesn't work. I'm not saying anything against ministers of finance or secretaries of the treasury would be the title here, but those ministers need to balance a lot of needs in a society. I think making the case, not just that this is the right thing to do, only the right thing to do on ethical grounds, but it's also the smart thing to do for the economy is a very important part of the puzzle, and that's exactly what we did. I mean, Felicia showed those numbers. If you quantify, for example, you just take all these people who drive themselves to poverty because they need to pay, that has a huge impact on the economy. These are people that liquidate savings. It has an impact on the savings rate. That liquidates very often productive assets. For example, I remember visiting a family of peasants who had one of these experiences. They had to sell everything. The family could no longer work the land because they had to sell productive assets. If you start showing how investing in health, how health is not an expenditure but an investment, and how that will actually help the economy grow, in addition to being the right thing to do on the basis of human rights and ethical reasons, it's not one or the other, it's both, then I think you can start making the case. But you need to come and with good information. That's why it's so important to have, for example, here the Institute for Health Metrics and Evaluation, another one of these great initiatives of the Gates Foundation, funded by the Gates Foundation, based here at the University of Washington, because that data will help you. So that's where I would start. Get the data, make the case, and then be able to derive concrete deliverables. What are the benefits? If you talk about abstract notions of insurance and quality and things like that, people don't connect. But when you actually link it to specific deliverables, that's when things happen. And that's when you say we're going to assure that everyone who has AIDS gets treatment, that no woman will die in childbirth, that all these preventable cancers will be prevented, for example, from cervical cancer, that we will detect things early. Just make the results real. We very often make the mistake as ministers of health of asking for inputs. Give me more doctors, give me more drugs, give me more buildings. That's not it. You have to say what you're giving, what you're achieving for that. And that, when you can actually show that those deliverables will be there, and that will not only save lives, but it will also help your economy to prosper and be more competitive, then I think you can actually break that vicious circle. And that's what countries with successful reforms have done.
Question?
Yes.
I have two quick questions. One is, do you consider India and China to be developed or undeveloped countries? Where are they part of, what denominator are they part of?
I mean, in these numbers, they are in the developing category, but they are, there's a whole set now of countries which we call emerging countries that have grown very fast and that have grown economically very fast and that are now facing the need for some of this.
Second question is that if we accept the notion that the cancer rates are increasing and our genetic makeup is the same, that there must be something we're doing environmentally or diet or whatever it is we're doing that's causing the increase in rates. And it seems to me that I won't say all, but a lot of the money we're spending seems to be on trying to cure something and not preventing things. And I'm wondering whether there's a disconnect here between where we spend our money, whether we should be spending more money on the front end, trying to how to prevent cancer and people getting cancer rather than treating it after the horse goes to the barn.
So, a big part is exactly what you said. Smoking rates are going up. Obesity, which is a risk factor for many cancers, including breast cancer, is going up. But there's another side to this. It is the notion that in health, we're always victims of our own success. Every time you deal with a cause of death, the risk of all the other causes goes up automatically. It's called competing risks. So what happens, for example, is that a lot of the children who may have had a genetic predisposition to develop leukemia didn't live long enough to express that genetic predisposition. They died way before from measles or from diarrhea or from an upper respiratory infection. as we, thanks to advances in public health and medicine, save those children, prevent those deaths, those children survive long enough. So you get to the situation that Felicia was showing, where cancer is the #2 cause of death of children in Mexico. Similarly with breast cancer, that's a disease that we don't have really any element for primary prevention. However, why is the incidence increasing? Because a lot of women who may have had a genetic predisposition would die in childbirth. As we become more successful in preventing deaths, and there has been a dramatic reduction in maternal mortality, it's exactly the same women who now live long enough to develop breast cancer. So one part of the picture is the idea that we've been victims of our own success. And that's good, It is better to live long enough to face one of these diseases than to die before you even have the chance to develop that disease or to express your genetic predisposition. The problem is, of course, you live long enough and then you face this environment with a lot of causes that we ought to be able to prevent. And that's why these reforms, if they only provide insurance, once you get sick, they will be very bad for the economy. You gotta do the upstream questions. The long-hanging fruit here is tobacco control. We all rejoice when there's an advance against tobacco in the United States, but that creates the incentives for those same companies to look for new markets. And if you look at just think about what's going on in China. About half of adult males in China today smoke. Now, China is already the second largest economy in the world. It's very soon going to be the largest economy in the world at the rate it's growing. All those men that are smoking get sick exactly at their most productive years. And they don't just die after smoking. They become sick for a prolonged period of time. They use a lot of resources in their treatment. So when China it's already a major player in the global economy, but when it's even more important, you will have this huge shock to the economy because people, especially men, in their most productive year, will be being disabled because they had smoked. If they don't do that earlier, it's no longer only a problem of China, it's a problem that affects the entire world economy. So it's an example of how interdependent we have become. But your point is absolutely right. And you go today to Beijing, and as I was there in February, and you couldn't see from the air pollution. You can see the airport was closed because of pollution. And people are so focused in the short-term growth that they're neglecting the whole idea of sustainable development, which is what are you going to do for the next generation. So we need a little bit of enlightenment and be able to do exactly some of those upstream interventions that will avoid some of these terrible consequences in terms of human suffering and of economic costs.
Let's take one last question from the microphone.
WHO is not a group that people in the US follow closely, but it's very different in low and middle income countries where WHO really sets a theme for how things should be addressed. As Dr. Nall pointed out, the UN has really shifted the focus on non-communicable diseases. But in the Global Action Plan that was just passed last month, it's really striking how cancer is mentioned peripherally in the context of this in comparison to lung, heart disease, and diabetes. And they seem to be terribly reluctant to talk about diagnosis and treatment. Clearly, they're concerned about costs. Dr. Frank, you spent a lot of time working at WHO. Do they have this right, or is there a different message that we should be sending so that it does get communicated in the way that you did in Mexico to other countries that have developing economies?
The discussion we have on cancer today reminds me so much of the way we were thinking about AIDS, in the late 1990s when finally antiretrovirals appeared on the scene and treatment was an option. And the same people were saying, we can't afford the treatment. It's all about prevention. 15 years later, we now see that actually, there's about 7 or 8 million people in treatment in Africa. It became affordable. The price of drugs went down. And we now even realize that distinction between treatment and prevention is not so clear-cut. It's one more of these false dichotomies, that actually treating people with AIDS is also a preventive tool. So every time we get into this dilemma, we should remember the lessons from AIDS. Furthermore, if you don't have comprehensive policies, it's exactly what happened with AIDS. Why would people go and get tested if they turn out to be positive? There was nothing that was going to be offered to them. It's only when you offer treatment that people started to get tested, which was a key for prevention. It's the comprehensiveness that we need, and we need to get beyond these false dilemmas. And I'm very distressed when I see that we haven't learned those lessons. There's so much we can learn from the enormous success that AIDS has been for some of these other diseases, and especially cancer. Cancer also has a big similarity with AIDS because these are highly stigmatized diseases. In many countries, people will not say the C word. It's stigmatized. People will go and invent all kinds of euphemisms not to say the word cancer. It was like AIDS, highly stigmatized diseases, and there's a lot we can learn. So I'm hopeful that because AIDS has to count along with the eradication of smallpox. That's one of the big victories in global health. We're not done yet by far, but it is a huge, huge victory. It's been a huge success, and back then, it was the same story, and I hope we'll apply those lessons now to cancer.
As we come down the home stretch, these are such important closing points. Princess Dina, Felicia, any final comments?
I would just like to comment on what the gentleman, I think it was the second question that you asked about Kenya, about what to do, where should they start. I just want to say that in our experience, I find that one of the reasons of our success, unless you have a wonderful health minister like Dr. Julio, with a great vision and all of these wonderful ideas, our success was based the fact that we were non-governmental. Because sometimes in many of these countries, I don't know, in Jordan it was the case, the government was fantastic in delivering primary and secondary care. But when it came to tertiary care, I would tell you for sure they would not have been able to attract all the fantastic doctors abroad with the fantastic degrees in oncology to come back and work in the governmental system. It would have been so much harder to, with all the resistance, to shake up a whole system. So what we did is we started this non-governmental organization, the King Hussein Cancer Foundation, and we had our center, and that's how we started, with fresh ideas, fresh board, without the bureaucracy, able to set good enough salaries to attract top brains to come back to the country. So that was one reason, and also we were able to engage the community. Once they started to see that we are serious, we're working in a very transparent way. We are the largest fundraiser now in Jordan, and probably in the region, from a grassroots community. And that has really, now, in fact, sometimes, we are now building a new center, all for fundraising. And don't belittle that, this can happen in Nigeria, in Kenya. I know, of course, you're much larger populations. We're only 6 million, containable. But sometimes when you show one example of an excellent care, then others will start to follow and you raise the standards. In fact, when we had our first accreditation as a general hospital, many other hospitals in the private sector upped their standards. Then we became the only center to be accredited as a cancer center. Again, this has challenged others to maintain standards. And people actually started to see, oh, okay, there is different qualities of cancer care, and you cannot have mediocrity in cancer care. So they all now come to our cancer center. So there are many, there are different ways. It's now becoming the other way. We are helping the government to train their oncologists in government hospitals. We are setting the standards for the country, for protocols and so on. So it can also work that way if it's easier, a step at a time, whatever works in any country.
So I like to think, as an economist and a patient, that doing something about cancer is about being an optimist and an optimalist, especially in developing countries. But one of the lessons to keep in mind is that prices aren't fixed and you shouldn't take them as given. They change, and it's all about hoping for them to drop. But one of the best ways to make prices drop is to increase demand so that people are lining up and requesting the service, and that will help to bring down prices. We've seen it happen with vaccines, we've seen it with hepatitis B, we've seen it with HPV, and I am sure that we can see it with much of what we're doing on cancer. But part of the key to bringing down those prices is to realize that we live in a world where we value a cure for a poor person the same as we value a cure for a wealthy person. And that, I think, will be a path not only towards justice, but one in which we can achieve the sorts of prices, the kinds of economies that can improve health for all.
You've been a wonderful audience, and now it's time to ask you for three things. First, if you feel moved, and it's hard to believe that anybody in the room doesn't, consider contributing to the Jill Bennett Endowed Lectureship. You can go to the UW Foundation website, look for the Jill Bennett Endowed Lectureship, and make a contribution if you're so inclined. Second, please join us afterwards for coffee and dessert just outside this room. And third, please help me in thanking these three brilliant, articulate, effective champions.